I'm sitting here with Anna Ferro and Thomas Albrektsson today, and we want to look into experience and backgrounds on our TiUltra and Xeal surfaces that have been launched 3 years ago. Obviously, the first question that's always addressed is why a new surface? And when we take a look back over the last decades, implantology has focused tremendously on bone integration, surface roughness, and bone behavior. And less attention has been directed to soft tissue healing and soft tissue maintenance over many years. So for us at Nobel Biocare, it was fundamentally important to take the learnings we have had over 20 years with our surface TiUltra and see what can we improve in order to not only sustain an immediate integration of our implant restorations, but also make sure that the longevity of our restorations is maintained. And this was basically the onset to the development of surfaces that not only take care of a fast and reliable osseointegration, but also bring the muco-integration concept to the public. Thomas, if we start with you, from a research and science perspective, you have been an integral part of the team supporting our internal experts and research development activities over the years. Maybe if you, in retrospect, look into where did we really start and what are the characteristics that are specific to these new surfaces?
Well, these new surfaces have some similarities, of course, with TiUltra in the sense that the surfaces are anodized. However, in the case of TiUltra, then we have a hybrid design, indicative, meaning that the surface topography, the roughness of the implant is much smaller in the coronal region, whereas in the apical region, the surface is clearly rougher and very close indeed to the roughness levels of TiUltra implants. This makes a more forgiving construction for many clinicians who for the real expert, I think that they succeed with most things. But this is really a very interesting approach in the importance of how deep you place the implant. That's less important. You have a hybrid design.
Thomas, when we developed the surface, there was a discussion on this hybrid design. Does it provide value or not? I think one of the most debated topics was, is a smoother coronal part of the implant integrating as well as a medium rough surface?
I called it before a forgiving design, but with that I meant that people could in the past have had problems with the depth of the implant when they placed it, right? Here, this is a very forgiving construction, and the minimally rough surface does not irritate the tissues in a manner that potentially a very rough surface could sometimes. So I think, therefore, to have this type of dual surface roughness, it's actually more than dual because it's a continuum towards the apical area, is very important. I must say that I also like the golden hue because if you have patients with thin biotypes, for instance, where the implants can sometimes shine through the soft tissues, then the golden hue gives it a much more aesthetical appearance in those cases than you have with an ordinary gray implant that could then be disturbing from an aesthetical point of view.
Going a little bit further from the implant surface now to the abutment surface, Xeal surface, in relation to the soft tissue, how do you see the value from a scientific and research perspective?
Yes. That's a very interesting approach because on the abutment side, generally speaking, we have been using the same or similar old abutments as Per-Ingvar Brennemark and our team introduced back in the 1960s. A very smooth surface. This is still smooth, the novel one, but it is also anodized and has some other characteristics, and it has been documented already in a published 2-year long study in a split jaw model, where it was demonstrated that there was a significantly high keratinized mucosa around the novel type of abutment. So I think they are also part of what we are seeing here is a very promising new implant, including the abutment.
Perfect. Anna, coming to you, taking on what Thomas just said, when it comes to the integration, let's focus on the short term. The integration of the bone, the integration of the tissues, what do you see clinically?
We just published at the AO basically our pilot study with 1 year follow-up. Unfortunately, only had 16 patients, but the results for us were incredible because, of course, we did not have any failure on the implant side, but more than that actually was for us the soft tissues, the hard tissues, and the sealing that exists, because we had the mean bone loss at the first year follow-up of 0.46 millimeters, and we had no biological complications. We had mechanical complications in 3 patients. We had 2 fractures of the provisional bridges. We had one screw of a prosthetic screw, but biologically we had no complications at all. So it looked like at least the clinical feeling that we had was that we have a very nice sealing between the abutment and the soft tissue.
So you say the muco-integration concept where you see a different type of behavior, hard to explain, but is that correct?
Yes, I see it. Well, my feeling is that actually there is something different. We are continuing the study. Now we already have 23 patients with, well, this is a little bit off the record because it's not published, but we already have the 23 patients with the 1 year follow-up. And actually, the mean bone loss now is 0.45, so it's decreasing, which is good, and still no biological complications. So I think it plays a role. The difference in this the surface of the abutment really plays a role. And for me, actually, the abutments are one of the biggest secrets on the All-on-4, because everything you do goes to abutment level. So this was a huge breakthrough, in my opinion, on abutment level.
Aside from the surface topic in regards to a new surface supporting the muco-integration of prosthetic or restorative components, how much value do you give, or how important is the fact that the Xeal abutments are placed at time of surgery or at time of second stage uncovering surgery, so have never seen a lab from the inside like we usually do on the restorative side? Do you think that is contributing to the really good clinical outcome that you just described?
I'm sure of it, really, because what we see is basically that when we evaluate our cases and we evaluate our implants, basically we evaluate through several parameters, being it probing the implant, the bleeding on probe, the accumulation of bacterial plaque. So we go through several parameters, and what we see, and also we published in this study, for example, was that for the same bacterial plaque accumulation, we see less bleeding of probe, we see less pockets, and basically also the bone resorption is very good.
So one of the reasons, Anna, for developing that was obviously to ensure that also the longevity of the implants can be maintained, and especially the hygiene maintenance, because we know from research that not all bone remodeling needs to be caused by inflammation, but there's a natural remodeling process going on over our lifetime. So how do you see the value of having the opportunity to clean and maintain the implant over decades to come?
For us, it's always one of our major goals. So we have settled ourselves some goals that we want to achieve with the total rehabilitation. treating dentless patients. And of course, we want immediate function. We want to deliver teeth in the same day. We want high statics. We want, I don't know, to have a simple protocol that we can teach more doctors to do it, lowest cost for the patient to achieve more patients. But I think one of our biggest goals are not just the immediate success, but the long-term success. I would like to have 100% success if possible, long-term, and this means I want my implants to be there, functional, with success, with no bone loss if possible, with no biological complications, and I think that every time that we can add something, being it to the protocol, being it to the products, I should, that even if it's 0.1 millimeter per year, I think we should go for it, because it all will increase the rate of our success and the patient's success.
So Anna, coming to a different topic that many clinicians might have on their mind, how difficult was it for you to integrate the new innovations into your daily routine?
Well, it was very easy, because here what we are talking about is basically just new surfaces. The products look basically the same, so the microstructures, to say, is the same. So for me, I did not have to change any kind of protocol, so my drillings were the same. The goal to achieve high primary stability was the same. I was drilling the same for soft bone, medium bone, and hard bone. So it was very, very easy. No effort at all.
And if you look a little bit back into the science that we based the new developments on, I think it was fundamental to have a solid base of data that we could then improve upon.
Well, this, I think, is the great advantage of Nobel Biochem. I'm a university professor, and I'm delighted by the fact that Nobel Biochem has always been very sort of strong with publications, with looking at the documentation. We did a study some years ago when we found that of all 5-year studies that we could locate, 74% of those were with the old Nobel machined implants. And the second most documented of all designs was actually the TiUltra, that had 11%. So all the other companies, they share the remaining 15% of long-term studies. And that talks for itself, I think. And this is enormously important, because we can, of course, do experimental studies. We can do even in vitro investigations in some cases. But nothing can replace a proper clinical study and clinical documentation. That's what we really can learn from. And therefore, I'm looking forward to seeing the TiUltra in the future to replace TiUltra as being the second most documented surface. We have to work hard on that.
We will, that's for sure. Thomas Albrektsson and Anna Ferro.
Thank you.